So it's my great pleasure to introduce Dr. Todd Purves to speak today. You can see his title. Dr. Purves is here actually looking at the job as the Chief of Pediatric Urology. It turns out that Todd and I actually talked to each other back in Baltimore about 12 years ago. I don't quite remember. Todd reminded me. Todd did his pediatric urology fellowship at Johns Hopkins between 2006 and 2008 when I was at University of Maryland. And I'm quite excited that, he is here because he's going to talk about his area of research is very closely related to what we've been looking at in terms of urothelial innate immune responses. Slightly different type of interventions that he's looking at in terms of urothelial response, but I'm sure we will all learn quite a bit from Dr. Purves' talk. So thank you very much.
Great. Thank you very much, Toby. And thank you guys very much for having me here. Did I screw something up? No? Okay. So first thing for the residents, it's basic science. And I know right now you got about a 5-minute window where you decide whether you're going to tune out and get a little rest or whether you're going to listen to this. I am a basic scientist, but I'm also a clinician. And so clinically, there are 3 things that we're going to cover today, that we're going to talk about today. The first is in cases of bladder outlet obstruction. So if you're a pediatric urologist thinking posterior urethral valves, if you're an adult urologist or an NIH study reviewer, BPH more likely, or if you're just a man over the age of 50, how does the immune system, the response by the immune system to bladder outlet obstruction actually lead to a lot of the damage that we see and a lot of the voiding dysfunction that our patients come in with? The second thing we're going to talk about is the bladder-brain axis, which Dr. Franco, I'm not sure he's here yet this morning, has been talking about for over a decade. And I'm going to show you some data today that suggests that he's probably right, for better or I know that. Well, maybe it's good that he's maybe it's good that he's not here yet. Okay, we'll move quickly. Oh, there he is. And then the last thing I'm going to show you is the what I think may be the first molecular mechanism for how we develop diabetic bladder dysfunction. It may not be the right model, but it's one of the first ones. So that'll be the 3 topics that we cover today. So these are all pretty clinically relevant. And I'm not in the biochemistry department. I'm in the urology department. So if my work is not relevant to what we're doing in the clinic, then there's really no point in doing it. Where am I aiming here? Off to a flying start.
We're going to get you all squared away.
We'll get there. Is there a, do this?
Yeah, you can absolutely do that.
Okay, I'll do that.
Okay.
So financial disclosures, not very long list here. I am a site PI for the Botox trial in children with neurogenic bladder, and that's my only disclosure. So I study inflammation, and more specifically, inflammation in the bladder or cystitis. Now, when we think of inflammation in the bladder, probably the first thing most people would think about is urinary tract infections. But I'm not going to talk a whole lot about that today. I'm going to talk a little bit more about things like bladder outlet obstruction and BPH, and all of the other things that cause inflammation in the bladder. Some things happen to patients like diabetes and stones, and an awful lot of things that we do to patients, such as stenting them and using various chemotherapies and radiation. The reason inflammation is important in the early stage is that this can cause pain. It can cause bladder overactivity. This is a very expensive thing that we treat in the U.S. And over time, chronic inflammation can cause scarring. It can cause denervation. And so this is where the bladders that you see of your octogenarians, when you look in the bladder and it looks like there's almost a plastic bag in there. So what causes inflammation? Well, the innate immune system is the beginning point for all inflammation. And it maintains homeostasis by in its reactions with things like pathogen-associated molecular patterns or PAMPs. These are things like LPS or flagellin that are in various uropathogens and other microorganisms. And this leads to the process of infectious inflammation. This is Ruber, Dohler, Kohler, tumor that we all learned in medical school. But actually, I'm not a big infectious disease guy. I like to mouth pipette, and so I'm not really a good person to be working with bacteria. So I've decided to study sterile inflammation, which I think has a lot more applications in urology. Sterile inflammation is what occurs when cells are damaged. They release these danger-associated molecular patterns, things like ATP, DNA, and these are recognized by the innate immune system and produce sterile inflammation. And the interface between the external stimuli and the innate immune system are pattern recognition receptors. Now, as required by law, I have at least one slide which is bewildering, and you know, that basic science slide that looks like this. Don't worry, you're not supposed to actually look at this and try and get anything out of it. But very briefly, to give you an idea of the family of pattern recognition receptors, one family that you may be familiar with are toll-like receptors. These are very important in urinary tract infections. So there is a fair bit in the literature about toll-like receptors in the urothelium. A lot of these other ones aren't terribly interesting to urologists. The C-type lectins, the double-stranded, and the RNA pattern recognition receptors. I should also point out, if you look at where all these guys go, it goes into the nucleus. I started out life as a protein chemist, not a DNA enthusiast, and so to me, that's a black box and it's magic and not very interesting. But this down here is where we're going to focus all of our attention today. These are on the nod-like receptors. These are cytosolic receptors, and the reason I think they're so interesting is because they actually do something, right? They created an inflammatory response, which I'll explain to you now. So when I started my work about 7 years ago in inflammasomes, this was the only paper written on inflammasomes in the bladder. This is Jörg Schopp's paper from Switzerland. Jörg probably would have won the Nobel Prize for his discovery of inflammasomes had he not passed away so early. But this paper, essentially, what they did is they took a cadaver and they took bladder, kidney, heart, brain, the whole bit, and they looked for inflammasomes. And the conclusion of the paper, at least relevant to all of us, is that inflammasomes exist in the bladder. And that was it. That was the only paper that was written on this topic. So when we started looking at this, the first question was, are inflammasomes actually in the bladder? What kind of inflammasomes are in the bladder? And where are they located? And so what you see is the NLRP1. This is actually important in the prostate. Probably prostatic inflammation relies a little bit on NLRP1. NLRP6 is kind of neat in the gut. It regulates mucus production, and there's some thought that it may actually regulate the microbiome in the gut. No one's actually looked at that in the bladder yet. Something to do, but not something I've gotten to yet. NLRC4 is another interesting class of inflammasome. It responds to flagellin, and so things like Pseudomonas infections are going to activate that inflammasome. But the one that we're going to focus on today is NLRP3. The entire talk today, I think there's one slide with NLRC4 creeping into it, which hopefully we'll pass through briefly. But the NLRP3 inflammasome is located in the urothelium. So what is the inflammasome? So the inflammasome is a supramolecular complex, but it starts with the nod-like receptor, and this is in the cytosol. And there are two steps by which NLRP3 forms an inflammasome and is activated. And this diagram I have here kind of explains a little bit how it works in a macrophage, which is where most of the inflammasome biology that we understand has come from. But initially what you have is you have activation of the TLR either through a DAMP or a PAMP. This upregulate through the NF-kappa beta pathway causes increased expression of pro-IL-1 beta. It also causes increased expression of NLRP3. Urothelium is a little different. Urothelium, I don't think the priming step is as important. But once you have this priming step in place, then this leaves the NLRP3 receptor open to activation by DAMPs such as ATP or PAMPs such as LPS. And what this causes is the recruitment of what's something called an ASC adapter, which then recruits procaspase-1. And procaspase-1 is kind of the active arm of the inflammasome. But this whole thing here is what I'm referring to when I talk about an inflammasome. Okay, it's a big supramolecular complex, and strangely, you can actually see it with a light microscope. It looks like little specks in a cell. So these are kind of neat for people who actually like to see this stuff instead of just cartoons. Once it's activated, what it does is it cleaves the pro-IL-1 beta and actually also pro-IL-18 to their active forms. It also cleaves something called gasdermin, which punches holes in the membrane, and it initiates a process of programmed cell death called pyroptosis, which is somewhere between necrosis and apoptosis, leans a little bit more towards necrosis. It's a pretty brutal form of cell death. And when this occurs, more DAMPs are released, which then act on its neighboring cells. And so you have a proliferation of inflammation. So this is the key of how inflammation starts and how it's initiated by the innate immune system. And some people call the inflammasome the central processing unit of inflammation for this reason. So as I showed you, we'd already shown that before we got too into it, we wanted to know if the inflammasomes were there, where were they in the bladder? And then the second question was, can you activate them with things that we would normally worry about as urologists, things like LPS from E. coli or ATP, monosodium urate. And what we found was that when you expose urothelium, rat urothelium, to these agents, you see caspase activity. And when I for the rest of my talk, when I say caspase activity, I'm essentially talking about the activation of the inflammasome itself. So the first paper we ever wrote on this was in 2014 in AJP. It was on a cyclophosphamide model, which is a really nice model for people who study inflammation. It's fast, it's cheap. You get results in about 2 days, well, really 24 hours. But it's not terribly interesting because you know, hemorrhagic cystitis, as brutal and vicious as it is not something we're seeing all the time. So we also looked at UTIs and published one paper on that. I didn't use actual bacteria. I used purified LPS because I didn't want to get sick. And then we really settled on, as a disease model, bladder outlet obstruction. And the reason for that, of course, is that huge problem, as you know, very expensive. And I turned 50 this year, so I actually have a personal interest in BPH. Still doing okay at the moment. And the other thing, too, I will say is it's a little weird to hear a pediatric urologist talk about BPH. I could talk about posterior urethral valves, but I have to put this stuff in front of NIH study sections. Most of them don't know what a posterior urethral valve is, and over half of them have BPH. So it's the model that I usually talk about when I'm talking about bladder outlet obstruction. So what happens during bladder outlet obstruction? Well, the bladder is continuously going through repeated bouts of high pressure, stretch, and hypoxia, followed by reperfusion as we go through our voiding cycle. It's been known for well over a decade or two, maybe even longer, that inflammation does occur in this process. And I didn't come up with that, but there was no real molecular mechanism by how you go from the insult to the inflammation. This then leads to the symptom of overactivity, frequency, and urgency. And then over time, you get decompensation. Okay, so my hypothesis then was that the NLRP3 inflammasome is actually the mediator of these insults into the process of inflammation. And the way this occurs is that when you make something ischemic, you develop things like reactive oxygen species, and you create DAMPs, which then activate NLRP3 and leads to that inflammation. So we couldn't do this on humans because they don't like it when you obstruct their bladders. So we recruited rats for this. And the first model we did was a 12-day model. Okay, and so this is a very acute model, very early on. And we had a tool available to us, glyburide. You're probably familiar, is the diabetic drug, FDA approved. At high doses, it's a very potent NLRP3 inhibitor. And so with these tools at our disposal, we looked at 4 groups of rats, control group, of course, and sham, and then we obstructed these animals, and then we saw what would happen if we knocked out NLRP3 pharmacologically. And the first thing we wanted to look at, of course, is when you obstruct a bladder, is NLRP3 activated, and does it actually cause inflammation? So we used a very classic model, probably familiar to a lot of you. We just put a little catheter, a little PE50 tube into the urethra, tie a suture over the top of that, and then remove the catheter. And there you have a obstructed rat. And the first thing we found was that NLRP3 is indeed activated when you obstruct the bladder. The other thing that was important was we found that when you administer glyburide in reasonable doses, that you can actually prevent this activation from occurring. Great. So what happens when you do that? Well, first off, we use a study called Evans Blue, which is a great assay. My kids loved this picture when they were younger. What you do is you inject a blue dye into the tail vein. And as you know, during inflammation, you get capillary leakage. And so if you have an animal that has inflammation in its arm, well, that's going to turn blue because the capillaries are going to be leaking. And so, for example, if you look at a bladder, if this guy here was our test subject, and he did not have he or she, actually it's a she, I'm sorry. If she did not have an obstructed bladder, there would be no leakage of Evans Blue. When you obstruct the animal, you have a tremendous amount of capillary leakage, as you can see in the picture on the right. And what we found was you can see a tremendous amount of leakage, tremendous amount of inflammation in the obstructed bladder. When you knock out NLRP3, you bring that inflammation back down to the sham levels. Obviously, there's a fair amount of inflammation in the bladder even during the sham because pelvic surgery on a rat does cause a fair amount of damage. So we felt confident at that point, based on that data, that NLRP3 is activated and it does cause inflammation, and that we could knock it out with glyburide. But nobody comes to the clinic complaining of an inflamed bladder. They come complaining of symptoms. And as a urologist, I always do my functional stuff first, because if it doesn't have functional consequences, I become a lot less interested in it. So how do we measure that? Well, we could do urodynamics on rodents. And this is a really nice picture that one of my Swiss students who came over from Zurich, he's now in Bern, Mark Schneider, he came over and we developed a machine. We actually use a pretty standard piece of equipment from Catamount in Vermont. This actually was modified so that we could do, we could measure EMGs on the sphincter at the same time. Won't be showing you too much data on that. But this is looks a little bit different than the urodynamics tracings that you guys are seeing in your clinics. Rats don't void quite like we do. You can see here, you have slow rise in pressure, you get the void, and by putting a balance under these guys, you can measure the amount of urine output at each void. So what does a normal rodent cystometry or cystometrogram look like? It looks like this one up here at the top. Sham, not a whole lot different. And the first thing I can show you about the obstructed animals, whether they get vehicle or glyburide, is, and I'm sure your professors who are teaching you about urodynamics are always telling you, how do you define bladder outlet obstruction? High pressure, low flow. And so if you look at kind of where our pressures are here, you can see that number one, we actually have obstructed the animals. That's, of course, very important to look at whenever you're evaluating these papers. The other thing, too, is we can measure the flow rate. Flow rate's kind of, honestly, these numbers are a little iffy because they pee so quickly that I'm not sure I want to put absolute faith in the number itself. But once you obstruct them, you can actually see them void, and it is significantly slower. So we know that these animals are obstructed. The other thing, if you briefly look at this, and I'll show you kind of the breakdown of the quantitative data, is that in an acutely obstructed animal, these animals develop frequency, urinary frequency, and if you look, when we administer an NLRP3 inhibitor, we abate that change. So you can see here, these are obstructed animals. You see a much more frequent, shorter intercontraction interval or greater frequency. And if you block NLRP3, that they do not develop the overactive bladder phenotype. Void volume, similarly, in acutely obstructed animals, again, they're voiding very frequently. They have kind of an overactive phenotype, and so their void volumes are quite small. If you then knock out NLRP3, that their void volumes come back to normal. Why? How? Well, actually, we have one of the world-renowned smooth muscle physiologists with us, of course, Dr. Weiss, who probably could explain a lot of this even better than I could. But the bottom line is, inflamed muscles are weak. And so when you prevent the inflammation in the bladder muscle, you have a muscle that can compensate for the obstruction. How does it do that? It just contracts longer. It keeps pushing until it comes out. It's not inflamed, it's not weak. And so it's able to contract longer, void longer, and actually empty its bladder. So the bladder volumes remain the same, and the frequency remains the same in a non-inflamed, acutely obstructed bladder. The other thing that we have known for a long time is that when you obstruct rodent bladders, you get denervation, patchy denervation over time. And so we wanted to look at this. We took the bladders out of these animals, and we used PGP-9.5 staining. This is a pan-neuronal stain, so we're looking at all nerves in this case. And then we were measuring nerve density. And what we find is that if you obstruct an animal, and this was actually it confirms work that has been done by several other groups, we showed that indeed at 12 days our obstructed animals had a decreased nerve density. And the way this occurs is by two mechanisms. Number one, you actually have apoptosis of neurons. There's also an increase or a hypertrophy of the bladder, which again is not a startling idea, but you have an increase in your denominator and a decrease in your numerator, and therefore your nerve density decreases. Glyburide prevents, to some degree, the nerve cell death. It also limits the amount of hypertrophy that we see, and so that protects nerve density. So how does this work? Because this isn't something I was terribly familiar with. Going back and reading the neuroscience literature, IL-1 beta absolutely has a role in neurodegenerative diseases like Parkinson's disease, Alzheimer's disease. Not coincidentally, the NLRP3 inflammasome is a major target right now for people interested in therapeutics for Alzheimer's and Parkinson. So what we did is we had a colleague of ours down in Eastern Carolina who grows pelvic ganglion nerves. We exposed these nerves to IL-1 beta, and we found, of course, that they die. And it does so in a dose-dependent fashion. So looking then beyond the other process that we were interested in besides denervation is fibrosis. And by that, I mean collagen deposition. So I'll be very specific about what we're talking about here. And if you look at the blue here, this is a MTS stain. You can see collagen stains blue, so control. There's always collagen in the bladder, as you know. And during outlet obstruction, after 12 days of outlet obstruction, you see a significant increase in the amount of collagen that these bladders contain. So what happens when you obstruct the bladder? Well, if you quantitate this, you get a rather significant increase in the percentage of collagen, over 30%. And if you knock out the NLRP3 inflammasome pharmacologically, you actually prevent this deposition of collagen. So at least at the early stage, it looks like we're protecting the bladder from injury. Where does the increased collagen come from? This was kind of interesting because if you'd asked me before we did these experiments, I always thought that maybe the urothelium would send signals to the fibroblasts, and that's where the main source of collagen is. And that may be partially true. But one of the things we found that urothelium actually does produce collagen itself, and we have a hypertrophy or hyperplasia of the urothelium. So one source could be that we have more urothelium producing more collagen. But I think a more interesting thing is that we did is we took the urothelium out of our obstructed animals and our control animals, and we just grew them up and measured how much collagen these guys produce in culture over a 24-hour period. And you can see that the urothelium that we pulled out of the obstructed animals have a rather significant increase in their collagen production. So then the real test of that then is because, of course, the end product of NLRP3 activation is IL-1 beta, does IL-1 beta itself, is that a stimulator of collagen production by urothelium? And indeed it is. If you expose urothelial cells to IL-1 beta, you can make them crank out large amounts of collagen. So we felt pretty good about this, that at least early on, in the early stage, that there is inflammation, it's NLRP3 induced, and that you can knock it out with an inhibitor, and that in doing so, you prevent irritative symptoms, you prevent denervation, and you prevent fibrosis. But nobody really cares about acute bladder obstruction because that's not the main thing that we see in our clinics. Very rarely, maybe in the ER with a big stone in the urethra or something like that. But really, it's the chronic phase that's interesting to us. And we looked then at a 42-day model, which is about as long as you can go in this model. The obstruction's rather severe, and once you go too far beyond that, you start getting into problems with kidney failure. But once again, we subjected these poor rats to 6 weeks of obstruction. And I think what we found was very interesting, because now this is something that I can really think of as a clinician as being important, right? So once you obstruct these animals for this length of time, by the end of that time period, normal rat bladder is about 1 milliliter or so in volume. These guys had a bladder volume of about 10 milliliters. So a 10-fold increase in bladder capacity. And when they void, they only void about about 2 or 3 milliliters. On the other hand, the animals that we treat where they're not, they don't have the NLRP3 induced inflammation, they also actually have hypertrophy. Their bladder capacity is up around 6 or 7 milliliters. So you still get, I mean, they're obstructed. So the bladder's still going to have to increase in size or capacity. But the interesting thing is that they can void to absolute completion. And so I'm not going to show you the data that goes along with it, but of course we looked, and the mechanism by which this works is that you do protect nerve density. You also limit the amount of collagen production, and that's why the stuff that I showed you about the acute model then leads to long-term preservation in a chronic model. So one of the things, where am I going? So I was just talking this morning, I have the renewal of the R01, and all the data I've talked to you about just now is not an R01, we're just finishing in the next few months. The stuff that where we're going with this particular project is this question right here. Your patients come in, they complain of early symptoms. If you get them early enough, a TURP is a really wonderful operation. And I'll be honest with you, as a pediatric urologist, if there's one thing I really miss doing, it's TURPs. It's just a great procedure. But as everybody knows, when you do it early, very effective. Great. Patients come back and tell you how fantastic you are and how happy they are. Once you get to where you really have irritative symptoms and you get towards the stage of decompensation, it's not a terribly effective procedure. And so the question going forward is, can we locate the time point at which we know that you are at the point of no return? Can we define the sweet spot for a TURP? Well, in a rat first, of course, and then we'll leave it to our adult urology colleagues to translate that into a more clinically useful. Yes, sir. We give them throughout. That's aim 2 of my renewal. That exact set of experiments. I'm not going to talk about this too much. About what I think. So in case there are any biochemists or molecular biologists that wandered into the room, they're going to be like, "Hey, you skipped really the most interesting, important part, which is how does this actually occur in the first place with the activation." And I'm going to cut to the chase because if we have time left over, I'll be happy to show you the experiments that we did. But essentially what we did is we took a bomb, and our colleagues, our collaborators in Clemson did this in the engineering department. You put the urothelial cells in a bomb, and you can pressurize them. And then using selective purinergic inhibitors, we found that what happens when you pressurize a urothelial cell is through exocytosis in the pannexin channel, you get a release of ATP. Again, this is stuff that's been done by other labs. This causes a cascade effect where you amplify the ATP levels that act on P2X4, which causes the activation of the inflammasome, and then initiation of inflammation. So we've got actually how pressure contributes to the actual activation of NLRP3, and then again, kind of telling you where we're going with all this because I am having the grant renewed yesterday. Don't know the score yet. We built a modified bomb. It's a much nicer bomb. We can not only pressurize these cells, but we can pressurize them, we can stretch them, and we can subject them to hypoxia at the same time. So over the next 5 years, I'm hoping to be able to tell you not just how pressure activates NLRP3 as a result of obstruction, but what the contributions are from hypoxia and stretch. Hypoxia is going to be interesting as well in the next model we talk about, which is going to be diabetes. So to switch gears a little bit and talk a little bit about both my clinical thoughts on voiding dysfunction in children and of course parroting a lot of what Dr. Franca has been writing since 2007 is when we think about people who come in with either interstitial cystitis or just 10-year-olds with voiding problems, the idea that this is all contained in the bladder is a bit wacky, right? The idea that the brain is not involved with this, it never made much sense to me. And so I was kind of interested in the bladder-brain axis. And one of the ways that, or the model that we're currently looking at is still cyclophosphamide. It's the model I always kind of go to at the beginning because it's cheap and it's fast and I can figure out if there's a there before I start working on expensive and time-consuming surgical models. And of course, as everybody knows, patients with interstitial cystitis have an awful lot of psychologic pathology. It's a little bit of a chicken and egg, which comes first. But we know quite well, and I don't think I'm going to say anything controversial when I say people who have IC are also people who are having psychological difficulties. And where I kind of got interested in this was, if you look at some of the psychiatric literature, is that NLRP3 induced inflammation in the hippocampus is actually one mechanism by which depression, anxiety, and difficulty with memory can come from. So, like I said, cyclophosphamide is my go-to cheap, fast model. It's one of the best studied. It's a very imperfect, very controversial model for interstitial cystitis. Importantly, cyclophosphamide does not cross the blood-brain barrier, and it's used as an immunosuppressant for IBD, or it can be. It's really kind of in the experimental stage for that. But the reason that's important is because when I show you data of what happens after an intraperitoneal injection of cyclophosphamide, it's important to realize that it's not an effect on the gut. Okay, it may not be the bladder, but it's not the gut, which would be probably the first organ system you'd worry about. So, simple set of experiments. We take rats and we inject them intraperitoneally with cyclophosphamide. This produces a hemorrhagic cystitis that, unfortunately, all you clinical guys are familiar with. And at 24 hours, we wanted to look for neuroinflammation. And by that, I mean caspase activity, IL-1 beta, IL-18 expression, breakdown of the blood-brain barrier, and of course, histology. And 24 hours later, what behavioral changes do you note? And we'll be talking about depressed rodents in just a minute here. Interestingly, when we started this, I really thought that we were going to find inflammation in the spinal cord, near Onuf's nucleus, and possibly the pons, because that's what we think of as, being kind of the neuronal input to the central nervous system from the bladder. I was wrong, but that's okay, because we found something which I think is actually maybe more fascinating in the hippocampus. And what we found, like I said, in the pons, really nothing going on there. The immune system there doesn't seem to be doing very much. However, hippocampus, we see a tremendous increase in the in caspase activity there. More importantly, we see inflammation. Not in the I'm not showing the pons data; it wasn't there. But you see IL-1 beta expression and IL-18 expression go way up. One of the neatest things about this set of experiments is, again, you get to see something. And, I am not just a basic scientist, I'm also a surgeon, and I like to see stuff and touch stuff. And if you look at the experiment we did with Evans Blue, you can actually see in animals that you've created from hemorrhagic cystitis, you can actually see the blue leaking out of the capillaries in the hippocampus. So there's no question that we know what we're looking at here. It's pretty obvious. The other thing that's very interesting is that glyburide does cross the blood-brain barrier, and it's effective in knocking down that inflammatory response. Yes, Dr. Prince.
So that's also your prefrontal cortex.
Yeah, not really. I think
Yeah, there.
right there. There may be some there as well. Yep, and the data you were showing me yesterday, that's what got me so excited. That what you're seeing with neuronal activity and what I'm seeing with inflammation appear to be happening in the same location. And I think actually the really interesting thing about this is that our first paper on this model was on the cyclophosphamide model, and the effectiveness at knocking down inflammation in the brain with glyburide is actually much more impressive than what we're doing in the bladder. So that gets into that whole question with even things like anticholinergics. How much is really acting in the bladder and how much is acting in the brain? We may be actually treating more about the brain than we are the bladder. If you look histologically, I think this is a normal, the fascia dentata, very important location for neuronal genesis. And in the animals that have been with cystitis, you're starting to see this is just the CP model or the CP brain, and this is a magnification of that. And what you see is that you have the activation of microglia. So you have activated microglia, activated immune cells in this part of the brain, which is very, very important because what you see here is pycnotic neurons. You're seeing nerves die. Okay, so by inflaming the bladder, you're actually causing nerves to die in one of the most important parts of neurogenesis in your brain. When you use the the NLRP3 blockers, you can prevent this inflammation. Yes, sir. So I think that it is bladder, but the problem is, you're absolutely right. It could be a response from the peritoneum. You know, burns can do this, liver injuries can do this, and so that's why right now this is an imperfect model. We're repeating all this in bladder outlet obstruction. We're getting some really neat data, but it's not quite ready to show you yet. So that's where we're going with this. We're going to do kind of the same set of experiments. But again, you know, I've showed you a bunch of histological slides, but what about behavior? Something we can actually be interested in as clinicians. And I started out life as a physical chemist. The idea that I'm doing behavioral studies on rodents is a little unsettling when we first waded into this territory, but it does kind of make sense if you look at how we do these kind of things. So if you give a rat a choice between sugar water and regular water, they'll figure out which one is which, and then they will not drink the regular water. They will only drink sugar water. They're like teenagers, right? They're gonna go for the sugar. And you can see in normal animals or animals that are just given iburide, that's important because it is a hypoglycemic agent. They're going to go for that sugar water every time. Once you've produced this inflammation in the bladder, produced the inflammation in the brain, you see that the animals don't really care. Like depressed patients, they don't care what they eat, they don't care what they're doing, and they'll just drink whatever they can get to. If you then prevent this, as we showed you before, the inflammation in the brain, that they don't exhibit this depressed behavior. And you know, one of the questions is that just sick behavior? Is it depression? Well, we give them Prozac as well, which shouldn't have as much to do with inflammation, although there's a little bit of a controversy there. But we're just treating these guys for depression, and sure enough, with the animals that have the cystitis, you can bring them back to normalcy with a little dose of Prozac. The other test that we use, because it's hard to trust these models, I think, there are a lot of variability, a lot of noise, and so the other test we do is we do the forced swim test, where you drop the rat in the vat of water, and the ones that are depressed tend to they become immobile for longer periods of time. And so you can see here that the animals with cystitis remain immobile for long periods of time. If you treat them with either an NLRP3 inhibitor or with Prozac, you can actually bring them back to normalcy. So our hypothesis at the moment, I wouldn't really call it a conclusion, it's more of a really good start, is that when you have inflammation in the bladder, this produces NLRP3-induced inflammation in the brain, and then of course you get depression as a side effect of that, but you probably also get a feedback. Of course, the brain also talks to the bladder, not just the bladder talking to the brain. So we have a lot of work to do on this. The CP model, as you pointed out, has a lot of questions. Are you really sure this is bladder specific or not? And so right now the model we've gone back to is outlet obstruction, where we know that it's a bladder injury.
Are you planning to look at pain phenotyping as bladder specific, like with a von Frey fiber pull test?
Haven't done those yet, but yes.
Right, and because that would be another sort of a whole animal phenotyping to get you some idea of bladder specificity.
Yes, and that's on the list of things to do. Absolutely. So with the time we have left here, and I will be quick, I'm going to talk a little bit about diabetes. Okay, and why do I care about diabetes, or why should we all care more about diabetes? By the way, I cherry picked these numbers. If anyone wants to quibble with them, you're probably right. But if you read one of the original case series back in the early 80s, up to 90% of patients, diabetic patients, can have some issue, some bladder issue at some point. And if you look at the WHO and the some of the projections about where we're going with our epidemic of diabetes, if it kept going the way it has been, 1 in 3 Americans would be affected by diabetes by 2050. Luckily, I think over the last 2 years, the numbers are looking like they're not going to meet that level, but it sounds scary, and it's a good thing to put into grants. But the thing that's interesting about DBD, and probably one of the reasons urologists don't really think about it or talk about it much, is that we don't really have a way to treat it, right? We send them to an endocrinologist, tell them to get their blood sugars in order, and we hope that works out for them. I'm a pediatric urologist. I had to justify why I was interested in this. And so I had Mary Ellen Kelly, who's our nurse prac down at Duke, go into the peds diabetic clinic and other non-diabetes clinics and give them a Vancouver questionnaire, which, if you're not familiar, is very similar in pediatrics to the AUA symptom score. And what she found was really kind of alarming. We found, consistent with a lot of other papers, that roughly 12, 13% of children, this is closer to 15%, of children, normal children, if you ask them or if you probe them with a Vancouver questionnaire, you'll find they have some form of LUTS. They do meet the definition of LUTS. In the diabetic children, you're already up to about a third, 33% incidence in children. These are mostly kids between the age of 10 and 15. So the OR on this is about 2.5. That's very significant. There's some interesting racial data here as well, which I'm not going to go into. But my point with telling you this is, number one, pediatric urologists should be worried about this. It's a chronic inflammatory process, and chronic inflammatory processes are best dealt with early, not late. The other issue is, as to the adult urologists, is that if we in pediatrics ignore this problem, these patients are going to become your problem pretty soon, and it may have already been 10 years into disease. So, like I said, it's progressive. It starts out early with a reduced sensation. And urodynamics, these patients don't report fullness until later, and then over time there's some decompensation. I'm going to kind of move through this a little bit quicker, but one of the reasons that diabetes scared me was because what doesn't go wrong in diabetes, right? We know that there's neuropathy, we know that there's some smooth muscle dysfunction, and we know there's urothelial barrier dysfunction. So diabetes really attacks the bladder on several different levels, and so it can be a little bit confusing as to where all this started. In the interest of time, I'm going to kind of go through very quickly some of the background data, but we know that peripheral neuropathy is associated with OAB syndrome in diabetic patients. About half of the patients in this study, about 80 patients, who don't have OAB have peripheral neuropathy, but almost all the patients with OAB do have peripheral neuropathy. And in rodent studies, we found that denervation occurs as well. So over a 20-week period in an STZ model of diabetes, you see a significant decrease in the nerves, the number of nerves that are in the bladder. We also know that early on in diabetic bladder dysfunction, you actually see an increase in the contractility of the smooth muscle, and over time, this decompensates and becomes weak. And then Lori Berger and Hannah Mitchell and these guys looked, and what happens in diabetes is the urothelium actually sloughs, and then it gets rebuilt with probably a completely different phenotype. And so there's a lot going on. I'm going to go through very quickly, the two things that we think of in diabetes: osmotic diuresis. That's why we send these guys to the endocrinologist, right? Go get your blood sugars under control. You're not going to be peeing all the time. Problem solved. Problem is, it's not. When you have hyperglycemia or even treated hyperglycemia, you're creating a tremendous amount of, metabolic dysregulation. These are DAMPs. These are things that activate the innate immune system. I'm going to have to skip this because I think we're running a little bit out of time. But the hypothesis then is that when you have diabetic metabolism, you're producing things like uric acid, free fatty acids. These are all DAMPs that activate NLRP3. You're producing a lot of reactive oxygen species and mitochondrial dysfunction and potassium cellular efflux. These are all known activators of NLRP3. So the idea then is, well, this should be active in NLRP3 in your urothelium. This should be leading to inflammation. This is not a genius concept. It was stolen, of course, like most good ideas, from colleagues in other fields. this NLRP3-induced inflammation as a driver of diabetic complications has already been shown in the retina, the kidney, the heart, the brain, and in the wall of our blood vessels. So when I first started looking at this, I thought, well, unless the bladder is unlike every other organ system that's looked at, that NLRP3-induced inflammation may be a major driver of diabetic bladder dysfunction. So the first thing we did was we subjected urothelial cells in culture to a lot of the damps that we know are really high in our diabetic patients: glucose, urate, HMGB1, and advanced glycated end products. And what you find is in a dose-dependent response, all of these are capable of activating NLRP3 in the urothelium, just like we showed you in the outlet obstruction model. So the first question we had was, does diabetes cause inflammation in the bladder? And again, based on Evans Blue data, you can see that there's capillary leakage by the time these Akita mice are 15 weeks old. They already have inflammation in the bladder. And we also know that NLRP3 is activated in the urothelium in these animals. So is that correlative or is that causative? How do you find that out? Well, the way you do that is you marry a diabetic mouse to a mouse that doesn't have diabetes but doesn't have an NLRP3, and a couple of these animals will be diabetic and not have NLRP3 in their urothelium. So what happens when you do that? Interestingly enough, the first thing you have to look for, of course, is does this affect, does knocking out NLRP3 affect blood glucose? Because obviously if it did, then you'd have a really neat cure or neat treatment for hyperglycemia, but it may not mean much to what we're doing with the bladder. And what we find is that no, indeed, when you knock out NLRP3, you don't really change the glucose levels and the diabetics, regardless of whether they have NLRP3 or hyperglycemic. And then, of course, we go back and do our urodynamic study. We're looking at both overactive bladder phenotype, which would be an early phenotype of diabetes, and the underactive, which is more of a late phenotype. And what we find is that at 15 weeks, our diabetic animals have a lower void volume, they have a much higher frequency, and whoops, we probably overshot our mark a little bit. We're already seeing decompensation with a large post-void residual. What do we see in the animals that are diabetic but do not have the NLRP3 inflammasome? Void volumes are preserved. Frequency still goes up. These guys are diabetic. They're still have an osmotic diuresis. So not too surprising there. But if you look, there's no decompensation of the bladder. So this gives us an idea that NLRP3 indeed is mediating inflammation in diabetic patients that may be affecting their bladder. Of course, as we know, peripheral neuropathy and neuropathy of the bladder is also probably an important issue. And since we've already shown in the outlet obstruction model that denervation occurs and is a product of NLRP3 inflammation, we looked and found that number one, our nerve density, as has been found by Dennis, Gary, and Cleveland and other people, actually does decrease in these animals. And if you knock out NLRP3, that they maintain normal nerve densities. And that is the source of an R01 that will be starting in April. We have a lot more to talk about, hopefully, over the next few years. But one thing that when we were looking at nerves, what we did differently than the outlet obstruction model is we were a little bit interested in why early on you have low sensation, why you have overactivity. And so we wanted to look specifically at the alpha fibers and the C fibers. And what we found was a little bit surprising, actually. Just like in the outlet obstruction model I showed you, alpha fibers do decrease in the diabetic animals. In the knockout, NLRP3 knockouts, those are preserved. That should preserve bladder sensation. What about the C fibers? Completely opposite. And this is something physiologically I still have not a whole lot of idea how this works. But for some reason, in the diabetics, you see an increase in the number of C fibers, which would explain your overactivity along with the lack of sensation. When you don't have NLRP3 to mediate that inflammatory process and promote nerve growth, C nerve fiber growth, then you end up with, you end up protecting that. So the kind of the thought process on where we're at right at the moment at the beginning of this grant is that the NLRP3 induced inflammation in diabetics causes a decrease in alpha fibers, causes an increase in C fibers, and that gives you that explains the early phenotype that we see in these animals and of course in our patients, which is decreased sensation an overactive bladder. And over the next few years, we're going to be following these animals. These are all 15-week animals, but much more interesting to be looking at the 30 and the 45-week animals. And that data will be coming out in a long time. Those are very long experiments to do. So that's the future for my lab in diabetes. The overall summary of the talk today then is number one, that the bladder urothelium does contain nod-like receptors which form inflammasomes. These are activated by relevant DAMPs and PAMPs that we know about as urologic clinicians. I've shown you, I didn't really talk too much about this model, but our lab has shown that in CP-induced inflammation, UTIs, outlet obstruction, diabetes. I didn't talk at all today about stones, but we've also done some work in stones as well because I work for Glenn Preminger, and so I have to. And that NLRP3-induced inflammation is not only important in the bladder, it's actually important in the central nervous system. So there's a lot of story to still be uncovered here. The grand conclusion, to reference Sticks, is that inflammasomes do play a central role in inflammatory urologic disease. And I would like to thank you all for coming. This is my group. I don't, unfortunately, one of your medical students is in here. There you go, Kunal Portis. He left us 2 years ago, and I think he's an M2 here at Yale. So anyway, thank you all for coming. I'm sorry to go as quick up to my time limit as I did, but if there's any questions or discussion, I'd be happy to talk to you. Yes, sir.
Thanks for that great talk. I know that you had a lot more stuff that you could show, but that was very impressive. I am curious if you have looked at urinary IL-1 beta and IL-18 in different clinical states. It seems like an obvious thing if you're talking about inflammasomes to look at different states of the disease to correlate with inflammation, because if it's urothelium, you can measure those markers pretty darn easily.
Yes.
Are you planning to look at it if you haven't? And longitudinal, I mean, all kinds of things.
Yes, so the answer is yes. I think that has to be done. I'm not a big clinical researcher, and I don't like writing IRB protocols, but that's something that, and I don't have a partner right now at Duke that is interested in running with that. But certainly if one was managing a big voiding dysfunction clinic, measuring IL-1 beta levels and IL-18 levels in these patients, and even NLRP3 levels to some degree, may be useful for charting the progress. And when we talked about trying to pick the sweet spot of where the terp's going to work, boy, wouldn't that be nice if we could tie that to an IL-1 beta level in the urine? When your patient comes in, he goes, well, it's kind of bothering me, but that surgery sounds really awful. If you could say, well, look, according to your IL-1 beta levels in your urine, you're not at the decompensation point of no return. So hang in there. You have the option of waiting. Or you could say, oh man, you're really coming up against that. If we wait another 6 months, you may be over that and done by the time we get to you. I think those are the type of clinical experience. And honestly, at the end of the day, everything has to be clinical because none of us treat rats or mice. So that's absolutely a good idea and where it needs to go. It's just at Duke, I haven't had somebody who's been willing to run with the ball. I've been too busy in the lab to tangle with the IRB.
Hi, thank you for the presentation. So we know in humans that a baseline history of depression or anxiety can predict incident lower urinary tract symptoms over the next several years.
Mm-hmm.
And then in animal models, if you put a mouse, if you do the stress test first, it will induce
Yep.
lower urinary tract symptoms and dysfunction. So have you looked at the other way?
No, and that's I mean, I drew it. It goes both ways, and we've been talking a little bit with Steve Zedrick and Jason von Batavia in Philadelphia. They're doing, and we actually had a conversation. In fact, I think Jason's coming down to Duke in a few months, sometime later in the spring. What they're doing in Philadelphia is they're stressing animals. They're coming from the opposite end. They're stressing, putting a mean rat in with the test rat, and then they're using optogenetics to look at how the input to the prefrontal cortex is then influencing the bladder. We're coming from the opposite direction, from the bladder to the brain, and of course we're focusing more on the immune system. They're more interested in neural circuitry, and so that is one way where I think with collaborators we're going to be able to start to figure out the back and forth. Because you're absolutely correct. It's which comes first, and I don't think it actually matters. I think that you can have somebody who's not depressed, who has bladder pathology and that produces psychiatric disturbances. And I absolutely believe in the opposite is definitely true, that people who are starting with stress, you know, high corticotropin level, you know, a lot of us are definitely at more risk for developing LUTs. And that may be one of the big things, you know, with guys with BPH. We know it's not just how big your prostate is now, right? There might be other things, and diabetes is probably one of them. Obesity is probably one of them. But I think you're right, psychiatric, your makeup, even if you don't have a true diagnosis, if you're an anxious person or a depressed person, you're much more likely to develop lower urinary tract symptoms. So defining the road in both directions is absolutely critical to really understanding what we're dealing with. Yep.
So you're studying glyburide as your chemical that's influencing things, but just an observation, talking to patients, some patients will report that if they take ibuprofen or pumpkin seed oil, they'll have less urgency frequency. Are there any other chemicals that you're studying that may influence inflammation?
So we haven't yet. There's actually, that's a very active area of research in the pharmaceutical industry. One of the leading candidates is something called MCC 950. Glyburide is not going to be useful for the clinical application. We're not going to give it to our BPH patients. The doses that we need to get NLRP3 inhibited, you would put somebody's blood sugars through the basement. So we need new agents that don't have that effect. There are lots of new ones. In fact, I gave a whole talk on this, just the new drugs coming out in Switzerland about 3 weeks ago. There's a whole, I could do about a half an hour talk on the new agents that are coming out. But we need new ones because glyburide's not going to be the answer for us in urology. Yes. Yeah. Yep. Mm-hmm. Yeah. So, that's something that I haven't really looked at in terms of NLRP3 or it probably isn't NLRP3. It's probably NLRP6. Inflammasome regulation of the microbiome in the bladder would be a fascinating project, but right now we know so little about the urinary microbiome. We don't even know what a normal urinary microbiome is. I think with some of the information we're getting about the microbiome, we're learning things like the idea of a urinary tract infection. Our current model of you have a sterile bladder, E. coli gets in and gives you an infection is wrong. I really think that some of the microbiome work that's so fascinating is that infection is probably really a better term rather than bladder infection would be bladder dysbiosis. You're upsetting the harmony of the microbiome, and then that's leading to a proliferation or an overpopulation of one specific organism throughout the bladder. That is, I think, I have some colleagues at Duke that are working on the microbiome, and I think once we get to a certain point, I think we need to merge and try and figure out how the innate immune system regulates our microbiome. Where that work's going on right now is in the GI tract. In the microbiome in general, that's been true. But I think it's a little bit premature for us as immunologists to start really trying to think about this until we know a little bit more about what we're dealing with the urinary tract. Mm-hmm. Yeah. I think the real money right now, if you're interested in the microbiome, is how does the microbiome in your gut regulate your metabolism? And it's looking more and more that that's important. And so, maybe half joking right now, maybe stool transplants from thin people will make you thin if you're. But there's a lot of really fun places you can. Yeah. But it'd be great. Weight loss through stool transplant sounds pretty easy.
So how do you reconcile that there's a model of a obese rat that, if given enough time, develops underactive bladder and it doesn't have diabetes? How does that fit in your
So great question. So if we leave type 1 diabetes out of this and just talk about type 2 diabetes, right now, the way the diabetologists think about this is that it's just a spectrum. So as you go from thin to obese to diabetic, you're just sliding along a scale, because adipose tissue produces a lot of danger-associated molecular patterns. It produces uric acid, it produces free fatty acids. And one of the models now for how we even develop type 2 diabetes is that these DAMPs are actually causing inflammation in the beta cells in your pancreas, causing inflammation, and that's why you develop type 2 diabetes. No, because it's essentially a mild form of diabetes, right? So being obese, even if you're not diabetic, you're still activating these NLRP3. You're causing NLRP3 induced inflammation in your eyes, in your kidneys, in your heart, just by being overweight. You don't have to go full-blown diabetes. That's obviously where we're looking, because we want to see the biggest effect, right? When you're studying new things, you want the biggest effect. But I think that you could say obesity is just a really mild form of type 2 diabetes from an immunologic standpoint.
Okay, let's wrap it up. I want to thank Dr. Purves for such a stimulating talk. Thank you very much. And I want to go ahead and clap. One more announcement. Next, 2 Mondays from now, February 25th, in the OBGYN department, Dory Lamb is coming to give a talk on genetics of male infertility. It's Monday from 12 noon to 1 if you're available. Dr. Lamb, for those who don't know, she's at Cornell right now, but she's been Baylor all her career and is a great speaker and has mentored a lot of urology people throughout her career. So I'm not going to be in town, but I know that OBGYN department contacted me. But Monday, 25th, 12 noon at the OBGYN conference room, which is in our same hallway.
I want to go to that. Yeah.
You're welcome.
I love Dory. She's fantastic.